Good day everyone. In today's video we'll be talking about fluid treatment in gastroenterology. We have talked about treating most of our infections in previous videos using fluids, fluid replenishment and dehydration treatment. In this video we will dive deeper into this concept where we will understand how, when, what and why. First of all, we should start by identifying our assessment of hydration. We should understand that dehydration has specific risk factors. There are patients where we should be more vigilant with our assessment and our investigation of dehydration. In children, for example, these are young infants. They have increased risk due to higher surface body area and body volume ratio. This leads to increased insensible fluid losses. These are losses that we cannot measure, for example, by breathing, by skin, by sweating, and they have milk as the main source of nutrition, which contributes to osmotic diarrhea and high renal solute load. So when our kid will be taking more milk as a part of his regular diet and his only diet, the milk can increase the osmotic gradient within the gastrointestinal lumen and will give us some increase in the diuretic component of our disease. And they have inherent tendency to more severe vomiting and diarrhea compared to older children and adults, because they will have a higher intoxication syndrome incidence. So, for developing countries, the risk factors that we would look at are, for example, severe symptoms. If we have a patient with frequent vomiting and water diarrhea, this predicts increased risk of dehydration, which is logical. In studies from the Indian subcontinent, some of the risk factors is failure to give oral rehydration solutions during the illness or be late, discontinuation of breastfeeding during the illness, because breastfeeding, although can increase the risk for dehydration for kids, but it is the main part of the kids' diet and the main part of the kids' replenishment mechanism. So although it can have a negative effect compared to older children, the negative effect is negligible when compared to the benefits of actually continuing to breastfeed. And other variables are if the age is less than 12 months, if we have more than 8 stools per day, more than 2 times vomiting, and malnutrition. South American studies showed that bottle feeding is an independent risk factor for dehydration compared to breastfeeding, since breast milk has immune components that can help, and the same risk factors for dehydration that are found in breast milk are found in bottle milk. Bottle milk will also increase the osmotic gradient, but without the immune component. Cholera has associated risk with dehydration, and other pathogens such as rotavirus in particular, Campylobacter and ETEC have comparable risk for dehydration. So, if you have clinical assessment of dehydration, we can use multiple schemes. One of the first and most popular schemes is weight loss. We could see the weight loss of the patient before the diarrheal disease and after, and this way we can measure the total loss of the weight, and this could indicate the severity of dehydration. The recent weight record enables accurate estimation, but non-recent record can be problematic. We have some specific clinical criteria where some cohort studies on subjects from 3 to 18 months have given us the clinical signs with the best correlation with dehydration. For example, a prolonged skin fold. We can do it by a skin fold test, where we take the skin fold, pinch it, and see how much time it takes to come back into the normal way. Dry oral mucosa, it's an important clinical symptom and sign. Sunken eyes. Sunken eyes is an indicator of severe dehydration, and it's one of the main symptoms of cholera disease. We can have altered neurological status, which comes when we have mixed mechanism of dehydration and intoxication. If you use the weight differential diagnosis method, then the weight difference associated with different level of dehydration is as follows. For mild dehydration, we have from 3.6 until 4%. In other systems, it can be from until 3 or 3 to 5. Then from 5 to 5.3, it's moderate, or 5 until 6 in different systems. And severe dehydration is from 9.5 or 9.8, or in different systems, it's over 9. We can look at capillary refill time, which is an indication of dehydration, although it lacks sensitivity and specificity, but it is a good indication of hypovolemia. The recommendations on assessment is to assess the risk of dehydration based on age, frequency of stool and vomiting, to know how many times we should assess the patient for dehydration and how closely we should monitor him. We can assess the presence and severity of dehydration using recent weight loss and the clinical examination. And here we have another time the values that should tell us that this patient needs extra examination. Later in this video, we will show using 3 different protocols how we can assess these patients. So, an important part of fluid replenishment in gastroenteritis is ORS, which is oral rehydration solutions. First of all, we should understand that from gastroenteritis we have body deficit of sodium, water, chloride, regardless of their concentration, because the patient might lose a specific amount of these electrolytes and water as well, so the concentration will be the same, but the bodily deficit is still present. Potassium depletion and acidosis can be also present. Hyponatremia and hypernatremia indicate the relative loss of water and sodium. Different disease will have different types of excretion, and especially if we have excretion of vomiting and diarrhea, or temperature excretion of water through temperature. These different types of water loss will give us different correlation and different percentages of sodium loss. That's why in gastroenteritis we can have hyponatremia, normonatremia, and hypernatremia. But anyway, the patient should be given fluids. So, rehydration fluid overflow. Rehydration fluid should replace both water and electrolyte losses. Oral rehydration therapy is effective in most cases of dehydration, and no other specific treatment is needed. The effectiveness of ORT was proven in major clinical studies during the cholera epidemics and in later epidemics related to different bacteria. As you understand, intestinal water absorption is mediated by an active transport process involving sodium and glucose. And this is one of the main pluses of oral rehydration solutions. Since they contain glucose, they can activate sodium glucose co-transporter function, even in patients with cholera, where glucose will help the absorption of sodium in the GI tract. ORT dramatically reduced mortality and cases of hypernatremic dehydration in the UK. So, if we are talking about composition of ORTs, we have different compositions of different elements, and each element has its own function and different variants within different companies. There is controversy regarding the ideal composition of ORS. For example, for as long as ORS was present, there was an WHO mediated ORS. It contained 90 millimoles per liter of sodium and evaluated for cholera patients. And this ORS was mainly indicated for underdeveloped countries for cholera epidemics, and their main goal was have maximal coverage of patients. So concerns about hypernatremia risk led to recommendations of lower sodium concentration of 50 or even 55 and 60 millimoles per liter in infants and children in controlled trials. Lately, WHO has given a new WHO ORS composition that has around 60 to 70 millimoles per liter, but this move came a lot later than the European counterparts. So in our video, in most of the literature nowadays, when we hear about WHO ORS, we are still talking about the old ORS, which contains 90 millimoles. If we talk about glucose, WHO recommends a glucose-sodium ratio of 1.4 to 1 to avoid excessive osmolarity. For European, it's even more, where we will have hypoosmolar ORS, which is recommended. Glucose can be provided as monosaccharide or complex carbohydrates, although there is still controversy in these complex carbohydrate or rice-based ORS. If we talk about potassium, bicarbonate, and base precursors, most products have around 20 millimoles per liter of potassium, and the inclusion of bicarbonate or base was intended to correct acidosis and promote water and sodium absorption, but evidence supporting their necessity in all patients is lacking. If we talk about patients with proven acidosis, then we should give this patient. Okay, if we talk about the recommended ORS composition for European children, and this is according to European Society of Pediatric Gastrohepatology, sodium should be around 60, glucose around 90, potassium around 20, and they add citrate. And the important part is that it is hypoosmolar. The osmolarity is around 240 millimoles. How do we rehydrate patients? So if we talk about the rehydration process, the rehydration should be gradual over 24 hours or longer. This rehydration used to be earlier and it lacked evidence. And now, by most authorities, including WHO and European, rapid rehydration over 3 to 4 hours are required. Estimation of dehydration degree as a percentage of body weight is still used by the European Society. The calculation of fluid deficit and administration of ORS to repair the deficit are needed. Oral rehydration via bottle, cup, spoon, or even enteral tube might be needed. Medical supervision and reassessment of hydration status during and after the hydration period are needed. If the patient vomited during rehydration, additional ORS should be given. So, whom should we give intravenous rehydration? And we will talk about hypernatremic dehydration. Children with signs of shock initially receive IV rehydration in most systems. Oral rehydration is possible, but intravenous route guarantees rapid rehydration in critically ill patients. Slowed fluid replacement over 12 hours is recommended for hypernatremic dehydration to reduce the risk of seizures. Usually in developed countries, the patient directly gets a full blood panel, especially if this patient is in shock and have risk factor for dehydration and hypernatremic dehydration. The use of ORT can itself reduce the risk of seizure during rehydration, so the patient can be taking simultaneously IV and ORT if he can. If we talk about monitoring of serum sodium concentration, it is crucial during rehydration to avoid rapid reduction, since rapid reduction of sodium leads to cerebral edema, convulsions, and seizures. Maintenance treatment. After we finish rehydrating our patients, we should continue on giving fluids, but in a different regimen called the maintenance regimen. This regimen is directed to prevent recurrence of dehydration. We should calculate the fluid requirement based on body weight. So, as we should know, the first 10 kilograms of body weight for each patient takes around 100 milliliters per kilogram. The max for a 10, it's 1 liter. After the first liter, we have 50 milliliters for each 10 kilogram, for each kilogram for the next 10. So it goes until 1 liter for 10 kilogram, then until 1.5 in 20 kilogram patients. And if the patient is more than 20 kilograms, then we add 25 milliliters per kilogram per day thereafter. And if the patient is overweight, the maximum weight that we use for maintenance is 70 kilograms. And we offer fluids ad libitum as much as patient wants, and children typically meet or exceed the calculated maintenance requirement. And if the patient cannot drink the whole required fluids needed for him, we can give him the remaining in IV solution. Fluid replacement strategies can be different. For example, we can alternate normal feeding with ORS feeding. We can administer 10 milliliter per kilogram of ORS for each diarrheal stool pass. In this situation, we should calculate each loss and add it. For infants and young children, each vomiting episode can result in a fluid loss of approximately 10 to 20 milliliters per kilogram. For older children, it's around 5 to 10 milliliters per kilogram of body weight. So, summary. Rehydration completion time frame should be around 3 to 4 hours. Fluid volumes in different degrees of dehydration are mild dehydration, 3 to 5%, around 30 to 40 milliliters per kilogram of ART over 3 to 4. Moderate is 50 to 100. Severe, it's 100 to 150. This is according to the European. We will go deeper into each kind of our regimen later in our video. So, IV rehydration with 20 milliliter per kilogram boluses of normal saline for severe dehydration and signs of shock, followed by ORT. ORT is safer than IV rehydration for hypernatremic dehydration, since the patient will have we will have better control on the natremic status of our patient. The use of slow ORT for hypernatremic dehydration for completion over 12 hours should be done with careful monitoring of serum sodium levels. We can provide normal drinks and administer 10 milliliter per kilogram of ORS after each water stool. Now we will talk about resuscitation in patients that are showing us signs of shock. General resuscitation is for the whole population. We need IV fluid resuscitation and use crystalloids. They contain sodium in the range of 130 to 150 millimoles with a bolus of 500 milliliters or 30 milliliters per kilogram over less than 15 minutes. We do resuscitation if the patient has symptoms of shock, of hypovolemic shock. We have decreased mental status. We have decreased BP, or we have high tachycardia. We should not use tetrastarch for fluid resuscitation. We can consider human albumin solution of 4 to 5% for fluid resuscitation in patients with severe sepsis. If the patient has gastroenteritis and sepsis, then we can use the 4 to 5% albumin solution, which have proven to be the best. In child, for a shocked child, we assume 10% dehydration based on body weight. Therefore, we calculate the total 24-hour fluid requirement, and we can use the two following formulas. We can use fluid deficit, which is 10% of the body's weight by 10. So we take the patient's body weight and divide it by 10. Or we can do another way where we could take the total fluid requirement of the patient, which is maintenance fluid plus the fluid deficit. This, we use it in patients who cannot drink, cannot take ORTs, and we give them all of the fluids. But first we start by the first formula. We replenish this deficit, this dehydration deficit. Then we reassess our patient, and we use the second one. So after resuscitation, we have maintenance. The main formula for maintenance, to see the rate, which is how many milliliters per hour, we should take the daily needs divided by 24 hours plus fluid losses. How do we calculate the needs? For adults, it's around 30 to 35 milliliters per kilogram per day with normal body weight, or 35 to 40 milliliters per kilogram per day with people with increased metabolic demands, such as patients with fever, burns, or major surgeries. Then we have another way of checking our maintenance requirement, what we talked about earlier, where the first 10 kilograms take 100 milliliters per kilogram. The second one have others, the third one have others. We can use both of them, and both of them will give us almost the same results. Maintenance for a child. For example, if an infant is from 0 till 12 months, the basal fluid requirement is 100 to 150 milliliters per kilogram per day. If a child is from 1 year till 10 years, it's around 100. If it's an adolescent, it's more like an adult, so it's 30 to 35. Then we should add the losses. And to calculate the losses, we should check how many times did the patient vomit? What is his renal output? So in the losses, we check renal output, how much the patient pee during the day. And usually, we don't add the peeing to our losses unless the patient is peeing too much. And this, we can check it. We can check the amount, and we can check if our patient have polyuria. But if our patient has normal urea, then the amount of fluid he is peeing and the amount he is excreting with urine is already within the maintenance fluid and his daily needs. If we look at vomiting as extra loss, then we can stratify our patients into 3 categories. Mild, where he have 5 episodes with minimal fluid contact. Moderate, from 5 to 10 episodes where the patient has a lot of vomiting fluid. And severe is more than 10 episodes. So if the patient has mild vomiting, the added liquids are not needed, and usually ORT is more than enough. And if the patient has moderate, we can add 100 to 200 milliliters of fluid for each episode of vomiting. And if we are talking about 200 to 300 milliliters of fluid, then it's for severe. For diarrhea, it is the same stratification but with different numbers, where 2 to 3 loose stools, 4 to 6, and more than 6, and the same with minimal, moderate, or significant fluid content. And the added liquid are the same. For mild, we don't add. For moderate, we add 100 to 100 milliliters. And for severe, we add 200 to 300 milliliters. Now we have finished with the general. We will be talking about each of our protocols. And we will start by the WHO protocol. This is the protocol pre-introduction of the new ORS. So we will be talking here about the old ORS solution, but instead of using this ORS solution, we'll use the new solution, but the clinical assessment and the clinical treatment is still the same. The WHO algorithm was made for cholera epidemics and underdeveloped countries. So it usually is used for underdeveloped areas or rural areas. It all starts with the question, does the child have diarrhea? If yes, then we should ask for how long and if there is blood or mucus. We should see and examine the patient. If the patient's general condition is lethargic, unconscious, or irritable, we should look for sunken eyes. We should offer the child fluid and see if he drinks eagerly or if he drinks poorly. We should pinch the skin of the abdomen and see how long does it take to go back. If it's more than 2 seconds, it's slow. And using this classification, we can stratify our diarrhea into multiple classifications. So, first of all, for dehydration, we can classify our patient according to the signs. If he has no dehydration, where we don't have enough sign to classify it as some form of diarrhea, some form of dehydration, the patient should be just given fluids, zinc supplements, and zinc is usually given to cholera. That's why they add zinc in this protocol. And food to treat diarrhea at home, which is the plan A. We will see all these plans. If the patient has restless or irritable mood, if he has sunken eyes, drinks eagerly and is thirsty, and the skin pinch goes back slowly, the patient has diarrhea, dehydration, and the patient needs a plan B. And if it has also severe classification, then we should refer to the hospital. And we should, like this is used to explain to the mother. We explain to her mother what are the severe symptoms, and that when she sees them, she should come back directly to us. Severe dehydration. For severe dehydration, 2 of the following signs should be: we should have sunken eyes, skin pinch goes back very slowly, he is not able to drink or drinks really poorly, and the patient is lethargic or unconscious. For these patients, we use the plan C and we refer it directly to the hospital. If the child is 2 years or older and there is cholera in your area, we should give them antibiotics for cholera. As we said, this protocol is indicated for cholera patients and is used for non-cholera patients in these areas that are underdeveloped. That's why we will be talking about when to go to the hospital, because sometimes going to the hospital can be a really big problem for the family, especially in underdeveloped rural areas. If we are talking about diarrhea more than 14 days and there is dehydration and no dehydration, this is already persistent diarrhea and they should be treated or referred accordingly. We will not go into this in details. Just we should know that if the patient has diarrhea, we treat the dehydration and refer it to a hospital. And to understand why we have persistent diarrhea, we should check our previous videos. If the patient has no diarrhea, we should just refer it to follow up in 5 days, give him multivitamins. We should exclude dysfunctional diarrhea, which is diarrhea that takes a little bit of time. It's diarrhea because of the intestine regenerating and not because of the infection. And if in 5 days the patient doesn't get better, we should refer it to a hospital. And if there is blood in the stool, then we treat the patient for 5 days with oral antimicrobial, depending on our area. And we have a follow-up in 2 days. If in 2 days the diarrhea doesn't start getting a little bit better, the patient should be directly referred to another hospital. So, we start with plan A. This is for patients with minimal diarrhea. We should counsel the mother on the 4 rules of home treatment, which are extra fluid, zinc, continue feeding, and we should explain to her when to return. The extra fluid is as much as the child will take, as much as he wants. We should tell the mother to breastfeed frequently and for longer time. If the child is exclusively breastfed, he should be given ORS and clean water in addition to breast milk. And if the child can eat, we should give him one or more of the following, which is ORS or food-based fluids such as soup, rice water, yogurt or drinks, and clean water. What we should see in the ORS, in the WHO, is the accent on getting the patient back to normal eating habits. How much should we give the patient? When, if it's up to 2 years, then 50 to 100 milliliters after each loose stool. This is extra to the fluid he is already taking. And if it's 2 years or more, then 10 to 100. With zinc supplements should be given, we can see the doses in here. And for continuing feeding and when to return, there is a special chart at the end. If we talk about plan B treatment, which is to treat some dehydration, then the amount of ORS should be given over 4 hours, where the patient will be staying in the clinic under our observation. And here you can see it's depending on the weight and on the age. So, yes, we use the age only when we do not know the weight and it will take too much to actually weigh the patient, or we are doing this over the phone and the parents cannot weigh the patient. We can use this chart, but it is a bit outdated and most of the countries kind of don't use it anymore, except if the patient is not in clinical settings and the consultation is done on the phone. And we should show the mother how to give the ORS solution, and after 4 hours we should reassess our patient. We should classify it for dehydration again and select the appropriate plan to continue the treatment. This patient can go to plan C, can stay in plan B, and then go back to plan A. And if the mother must leave before completing the treatment, again, we are talking about rural, undeveloped countries, we can show her how to prepare the solution at home, and the solution could be made at home easily with salt, water, and sugar. And we should show her how much to give to finish the 4-hour treatment at home. And we should give her enough ORS packets to complete rehydration if it is available. So, we explain the 4 rules of home treatment, the same as with plan A, and we let them go home. Now, if we are talking about plan C, then the patient has severe dehydration. We should follow the following algorithm. The first one, can we give the patient IV? This question is given because in rural underdeveloped areas, we will not always have enough experienced healthcare professionals who can get IV access in a small child. If it is possible, then we should start our IV access by giving ORS by mouth at the same time and IV access. We give 100 milliliters per kilogram of ringer lactate or normal saline if ringer is not available. And the first take should be given in 130 in 30 milliliters per kilogram in the first hours. If the patient is under 12, to not risk hypernatremia. And if the child is from 12 to 5 years, we can give it around 30 minutes. And the next 70 milliliters per kilogram should be given by 5 hours or 2.5 hours. So we give the patient 100 milliliters per kilogram. The first 30% are given in 1 hour or 30 minutes. And the next 70% should be given in 5 hours or within 2.5 hours. At the same time, we should give the patient ORS as much as he can drink. It is recommended 5 milliliters per kilogram per hour, but usually it's the most practical way is just give him as much as he can. We should reassess the patient after 6 hours or after 3, depending on which criteria or on which scheme we decided to use, and the patient's age. And accordingly, we will switch the patient to other plans or keep him in this plan. If we cannot give the patient IV fluids, then we should check. Is there anywhere around us where the patient can take IV within 30 minutes? If yes, then we refer him urgently to this hospital, and when during this time until the patient can go there, we will give him ORS. If the patient cannot get to another hospital within 30 minutes to give him this IV fluids, then the patient can be given the fluids using a nasogastric tube. So, our next question, if we cannot give the patient IVs and the patient cannot go within 30 minutes to another hospital, can he take nasogastric tube? Like, do we have trained professionals who can give him? If yes, then we should give him over 6 hours 20 milliliters per kilogram per hour, which is around 120 milliliters per kilogram. If we gave him using IV 100, here we give him 120 because 20% of this fluid will not be absorbed. And we assess this patient every 1 to 2 hours. If we have vomiting or abdominal distension, we give the fluid more slowly. If the hydration status is not improving after 3 hours, we send him to another hospital even if it's further than 30 minutes. And if after 6 hours we finish, we should reassess how the patient is. Once again, if our patient cannot be given IV, cannot be transferred to another hospital within 30 minutes, and we don't have any patients who can, or any healthcare workers who can give him a nasogastric tube, then we check. If the patient can still drink, then we try to rehydrate him by ourselves at least for 6 hours using the scheme, and to assess him in 3 hours. If in 3 hours the drinking patient doesn't get better, we refer him to another hospital even if it's far. If the patient cannot drink, we directly refer him. We don't wait the 3 hours, and we refer him to another hospital. The scheme might be a bit complicated, but presented during this, like using this way, it becomes a lot easier. Now, if we are talking about fluids, this scheme is specially made for mothers. The patient should continue to breastfeed, and it should become more frequent and longer at each feed. If the patient is not exclusively breastfed, we can add other fluids. This is the mother chart. this is the advice for the patient's mother when to return to our hospital. We start by explaining to her that if the patient has other than diarrhea, pneumonia, dysentery, fever, measles, and dehydration, then the patient should come in 2 hours. If he has persistent diarrhea or ear infection or any other of those problems, he should come within 5 days. And if the patient has low weight, he should come in 30 days. If the mother sees any of the following, she should come directly. Now we'll talk about the immediate red signs for the mother to come back. If the sick child cannot drink or breastfeed, if he becomes even sicker, if he develops a fever. Because a small child with fever and diarrhea means two things: either intoxication syndrome or bacterial diarrhea that needs antibiotics, or needs assessment for antibiotics, at least assessment by a professional. If the child has no pneumonia, cough, or cold, but has fast breathing and difficulty breathing, the patient should be referred directly to us. And if the patient has diarrhea and we start seeing blood in stool and is drinking poorly, the mother should come back to us. This is the same follow-up care, but this is for different etiologies that can give us dehydration. This is not within the scope of our video, that's why we will just skip it. So, ESPGHAN is the European Society of Pediatric Gastrohepato... I will not say the whole name. It is the European protocols for gastroenteritis. We start our video with the understanding that the main difference between this protocol and other protocols is the use of hypotonic osmolarity solutions. There are hypotonic hypoosmolar solutions that are not recommended by WHO but still recommended by the European Society. They contain 60 millimoles. For the assessment of the patient, we should use the following variables. And if the patient has 1 or 2 symptoms of a condition, we use the upper one. So if the patient has dry, very dry mouth and tongue, and the pinch retracts very slowly, then it's already severe. Or if the patient has unconscious and floppy lethargic situation with absent tears, for example, it is severe even if the other symptoms are within some dehydration. It is really similar to the WHO one, and it uses the body weight percent as an indicator, with 5%, less than 5, 5 to 10, and more than 10. It is really easy to remember, and it is one of the most simple protocols, and that's why it became really popular. It has some specificities. For example, it has specific indications for nasogastric rehydration, and here we will have the degree of evidence, scientific evidence by 1, 2, or 3, and the degree of recommendation by A, and B. This is important because this will help us understand how much these recommendations have been studied. In European Society protocols, the nasogastric tube is used before IV rehydration if the patient isn't able to drink ORS. This is a big difference from other protocols that recommend the IV rehydration before using the nasogastric tube, or use the nasogastric tube only if the patient cannot be given an IV. It is used because nasogastric rehydration has fewer adverse events and shorter hospital stays and gives us shorter hospital stays in patients compared to patients using IV rehydration. We use a rapid 40 to 50 milliliters per kilogram in 3 to 6 hours, and the standard NG rehydration regimens are equally effective. Usually, they give it in rapid 3 to 6 hours because it's more practical in clinical settings, but using a 24-hour regimen can give us the same results. The indication for IV rehydration in these protocols are when the patient is in shock, has altered consciousness, and severe acidosis. And if we have lack of improvement after oral or NG rehydration, or if we have persistent vomiting and abdominal distension and ileus, which is complications of the NG tube, then we will use IV. But as we can see, the level of recommendation and studies behind this recommendation. If we take oral rehydration, it is the first line. IV rehydration may be needed only for specific cases. And when administering IV fluids, it should be isotonic or lactate ringer for shock cases, and it should be rapid. Rapid solution is 20 milliliters per kilogram per hour for 9% or of 9% saline for severe dehydration, and they should be given until the shock goes away. We can consider dextrose containing solutions for maintenance when we already get into the rehydration, like when the patient is not dehydrated or in shock anymore and we are just maintaining his fluid status. We can use at least 0.45 saline during first 24 hours in some patients to prevent hyponatremia. This can be used especially in patients that have increased risk for hypernatremia and hypernatremia. We can add 20 milliequivalent per liter of K+ if the child urinates and the serum electrolytes are known. The rates are 20 milliliters per kilogram for 2 to 4 hours, followed by oral rehydration or dextrose solution, and this is suitable for most patients, but usually after 2 to 4 hours we just reassess our patient. And a very rapid IV rehydration can lead to electrolyte abnormalities and prolonged hospital stays. This is the result of a study. Like when reading European Society protocols, you can see that all of their recommendations come directly with references to the studies and their assessment of the credibility of these studies and recommendations. I really advise anyone to actually go and read the full document, as it can be really interesting. The fluid composition for rehydration are isotonic 0.9% saline or lactated ringer for initial rehydration, and we can add glucose to saline after fluid restoration and during maintenance, but this is a third stage of credibility and a C recommendation. If we talk about hypernatremic dehydration, it is rare during acute gastroenteritis, especially if we have already followed our protocol and because patients with specific risk factors are becoming less and less. The use of isotonic saline for fluid deficit replacement and maintenance is recommended. We should reduce the fluid deficit slowly over 48 hours according to these protocols, and we should monitor plasma sodium frequently. If we talk about general recommendations, then rehydration, we should use reduced osmolarity ORS. The use of reduced osmolarity oral rehydration solution with a sodium concentration of 50 to 60 is recommended for the first line therapy of children with acute gastroenteritis, and it has showed better clinical outcomes compared to normal or full strength WHO ORS in terms of reduced stool output, vomiting, and need for supplemental IV therapy. If we talk about modified ORS, which is ORS with different additives like rice starch or tetrastarch and all of those, there is no sufficient evidence that the European Society deems credible to recommend for or against the universal use of such ORS. If we talk about nutritional management, then early versus late feeding, early resumption is recommended. The studies suggest that early refeeding promotes regeneration of the enterocytes and the epithelial layer of the gut, and this decreases the regeneration phase and decreases the diarrheal symptoms in the post-infection phase. As we talked modified formulas, which is the use of lactose-free feeds is not recommended in outpatients. And there is no evidence for diluted lactose-containing milk. That's why the recommendation stays to continue breastfeeding and continue normal feeding. If we talk about pharmacological therapy, the recommendations of the European Society, according to antiemetics, the ondansetron may be effective in treating vomiting in children, especially with mild to moderate dehydration, and especially if ORS have failed. Other antiemetics like dexamethasone and metoclopramide do not have sufficient evidence and are most of the time contraindicated. Antimotility drugs as loperamide are not recommended, and they might be even contraindicated. If we talk about adsorbents, then diosmectil is an adsorbent and can be considered for management of acute gastroenteritis and have been shown to reduce stool output and duration diarrhea in some studies. If we talk about anti-secretory drugs like resicadotril can be considered as an adjunct for ORS in managing acute gastroenteritis, and it has been found to reduce the duration of diarrhea and increase the proportion of patients who recover. Now, going to the NICE protocol, which are the UK specific protocol. These protocols were developed during almost the same time as the European protocols and are highly influenced by them. So the main clinical assessment method is weight and signs. So if we cannot check the weight of the patient, we check for his clinical signs. They are almost the same as other protocols, but the NICE protocols has specific signs. They call them the red signs. If the patient has one of the red signs, he is directly going into severe dehydration and shock, and this patient needs referral to a hospital directly, and he needs resuscitation regime of treatment. Here we can see them, which are the red signs. And we have two classifications. The first one is the patient classification according to his weight, according to his signs. Here it is a classification only for us, the doctors. It is to understand if the patient has clinically detected dehydration, if he has clinical dehydration or shock, since treating the shock will be different than treating dehydration, than treating just symptoms of acute gastroenteritis. And as you can see, all the symptoms that are in the red flag area are the same in the clinical shock almost. So the red flags are if the patient is deteriorating, if the patient has altered responsiveness, which is CNS disturbances, if the patient has altered responsiveness, which is, for some reason, it's 2 times. First time is as a symptom, second time is as a sign. And it has sunken eyes, tachycardia, tachypnea as symptoms of circulatory problems, and reduced skin turgor, which is skin coming back after folding. Why do we have this classification? Because symptoms can be asked on the phone, while signs are only examined by the healthcare professional. It is really important for us, because if the patient is deteriorating and have altered responsiveness, it means the patient's symptoms need actually be looked at as signs. For diagnosis, this is one of the most practical guidelines, and that's why if the patient has, for example, prolonged capillary refill, weak peripheral pulse, this patient is already in shock, and it doesn't matter if he has dehydration or not, this is full shock. We should treat him accordingly. And that's why I actually really like this scheme of diagnosis. So now if you go on to the ORS used and recommended by the NICE protocol. The WHO, which is the pre-2002, which is the, how we call it, normal classical WHO. As we can see, the osmolarity is high, the sodium content is still 90, and we don't have citrate. This used to be the old one, and it is not recommended by the British protocol. The new WHO solution is hypoosmolar. It contains 75 millimoles of sodium and contains less chloride and 10 millimoles of citrate. This is also not recommended, as it is not hypotonic and hypoosmolar enough for them. They have Dehydration and Electrolyte. These two are British companies that have a decreased osmolarity of 240 and 250 accordingly. One of them has a little bit more glucose, the other one has less glucose. They both have more glucose than the new ORS, but their sodium composition is a lot less. The British protocol is more inclined to prevent hypernatremia than the other protocols. That's why they have bigger accent on the sodium content and not on the other contents. If we talk about fluid displacement, then they use low osmolarity ORS solutions of 240-250. They administer 50 milliliters per kilogram over 4 hours, along with maintenance. This is one of the main differences, as they have a bigger volume compared to other protocols. If we offer ORS solutions in frequent and small amounts, it will improve the tolerance. Supplementation. The protocol advises us to supplement the ORS solution with fluids, which are the usual fluids, such as milk, feeds, and water. But they advised against fruit juices, as they contain too much sugar for the patient's condition. And carbonated drinks are also contraindicated. And if the child refuses to take sufficient quantities of ORS and does not exhibit red flags symptoms, the patient is allowed to take more and more and more of these non-ORS fluids. But if the patient is having red flags, then we should stop this and go into the next line, which is nasogastric tube administration. If the child is unable to drink ORS solution or has persistent vomiting, we should consider delivering ORS via a nasogastric tube. But we should weigh the benefits and the drawbacks of NG administration against the alternative of IV therapy. We should consider the child's condition, distress, and potential complication. How to monitor? We should regularly assess the response of oral rehydration through clinical evaluation. We should monitor changes in hydration, clinical signs, and symptoms of dehydration. How we should deal with severe dehydration and shock. In cases where the children exhibit clinical features of which are red flags symptoms, we should provide close and continuous observation. And if there is evidence of deterioration despite ORT, we should directly initiate IV therapy to restore circulation and clinical stability. We should revert to ORT directly once stability is achieved, if ORT is still tolerated. If the patient has hypernatremic dehydration, ORT is preferred in these cases, and there is no evidence to support ORT being less safe than IV therapy in these cases, which is a direct contradiction of what is written in the European Society protocols. Who is correct? How can we know? Some of them deem some studies non-reliable, some of them deem the others reliable. That's why the British experts and the European experts agreed to disagree on this matter and left the matter to the individual doctor assessment of each patient. But usually doctors just go by the protocols to avoid any extra complications later. And for our viewers not living in European Union and the UK, then you can use any of the protocols that you deem appropriate, or use your local protocols. If we talk about the ORS composition, we already said the specific composition, but there is no evidence to support differences in clinical outcomes between different solutions that have still the same range. So there is no one big solution that's better than the others within the UK market. Talking about cereal-based ORS solutions, they may reduce their losses compared to glucose-based solutions, but the evidence is limited, and it mostly applies to cholera since it is one of the best studied infections in this area. Rice-based ORS solution has shown some evidence according to cholera, but with other disease there is not enough evidence. Talking about IV solutions and IV treatment, it is used to manage shock. First of all, we administer a rapid infusion of 20 ml per kilogram of 0.9 sodium in cases of suspected or confirmed shock. If the shock persists, we should have it as a bolus. If the shock persists after the initial infusion, we immediately give another infusion of the same. If the child, especially if we're talking with child, don't respond, then we should consult a pediatric intensive care specialist after the second infusion. For severe dehydration, when should we transition into IV therapy? We use IV therapy for children with severe dehydration when oral therapy is not successful despite appropriate treatment with ORS. We should not directly start IV in dehydration patients. We should assess the patient's condition and monitor dehydration status before transitioning to IV. We only use it after careful evaluation if there is clear evidence that ORT is failing. The British protocols like the IV therapy compared to the NG tube, but in general they still use it after long consideration, and they try to avoid it as much as possible. If we are talking about the fluid composition, then a solution of 9% sodium chloride or 9% sodium chloride plus 5% glucose for fluid deficit is used for replacement and maintenance during IV. So the British protocol uses hypoosmolar hypotonic ORS solutions, but they don't really like to go out of the classic saline or saline plus glucose replacement during IV therapy. They regularly measure plasma sodium, potassium, and urea and creatinine and glucose when the patient is on IV therapy. They consider adding IV potassium supplementation once the plasma potassium level is known. They don't add potassium as just as regular maintenance for everyone. This global potassium use is not recommended by the British protocol. If we talk about hypernatremic dehydration, then the urgent expert advice for fluid management is needed. This is usually the ICU doctors or the pediatric ICU doctors. They use isotonic solutions for fluid deficit and maintenance and replace it slowly, typically over 48 hours. And they maintain the plasma sodium frequently. When to introduce ORT during IV? We attempt early and gradual introduction of oral rehydration therapy during IV fluid therapy. If the child tolerates it and is already taking enough fluids, then we discontinue IV and complete only with ORT. After rehydration, breastfeeding and fluid intake is still encouraged to prevent repeated dehydration. As we said, if the patient is at increased risk of dehydration occurrence, we provide 5 milliliters per kilogram of ORS solution after each large watery stool. The high-risk groups include under 6 months especially, and under 1 year, low birth weight, those with more than 5 diarrheal stools in the previous 24 hours, and those who have vomited more than twice. The rate of IV administration. In these protocols, we don't have specific IV rates. This protocol emphasizes the importance of further research in this area, and it leaves this question up to the expertise of each doctor. So if we talk about other adjunctive therapies, then vomiting during ORS is common, but it doesn't require any additions. In persistent and frequent vomiting cases, ORS or IV fluid IV fluid or ORS using nasogastric tube might be recommended. Oral ondansetron may enhance ORT success, but it should be used cautiously due to possible risks. Therefore, other than ondansetron, no other specific drug is recommended as a empiric use, for empiric use and for regular use. If we talk about antidiarrheal agents, they include charcoal, smectate, kaolin, resveratrol, bismuth, and loperamide. If we talk about kaolin, it has no supporting evidence. Charcoal has limited. Smectate shows short-term potential in hospitalized patients. Resveratrol antidiarrheal effect requires more research in UK-specific patients, although it has proven in the European population. Bismuth subsalicylate is not having consistent results, and loperamide is not recommended due to licensing and adverse effects, since it is kind of a controversial topic in the UK. If we are talking about nutritional management of the patient, it was believed that earlier introduction of feeds after acute gastroenteritis could worsen the illness and prolong diarrhea. That's why patients used to fast for 24 hours or longer. However, evidence now supports the earlier introduction of feeds due to the positive effect of luminal nutrition on mucosal growth and regeneration. So even when the infection goes away, we still have adverse effect, but earlier introduction of food minimizes this effect. It reduces abnormal intestinal permeability and promotes enterocyte regeneration and recovery of the brush border membrane disaccharides. If we talk about the effects of refeeding and gradual feeding, many studies have shown no advantage to gradually infeeding feed concentration during the recovery phase. In malnourished children, refeeding has advantages. Both groups received ORS over 4 hours, with the early refeeding group immediately resuming normal diet. This is a study made by the multicenter European study. No difference was observed between the two groups. The group that has late refeeding in weaned children and the group that had early refeeding, and it was the symptoms, the incidence, and the weight gain were almost similar. If we talk about lactose intolerance, then in most patients with rotavirus infections and other infections have transient lactase deficiency. That's why they become lactose intolerant. Discontinuation of breastfeeding during illness is associated with increased incidence of dehydration. That's why even with this lactose intolerance, we should continue breastfeeding. It may actually reduce stool output, and as we talked, according to European Society, the rehydration corrected over 3 to 4 hours should be directly followed by reintroduction of normal food. Breastfeeding should be continued, and lactose-free formulas are rarely necessary unless the patient has acute symptoms of lactose intolerance and the stool pH is acidic. Some patients have congenital sucrase isomaltase deficiency. These patients need specific formulas when having gastroenteritis. Most of our formulas and most of our protocols are directed for children because children are the most risk factor group, are the group with the most risk factors for dehydration and adverse clinical outcomes. And dealing with them is harder because they have higher incidence of morbidity in this disease in general. Like, they get sick more often with gastroenteritis than all the other parts of the population. And that's why most of our protocols are indicated for them. We can talk about pharmacotherapy, using antidiarrheals, using antimicrobial agents, recommendations regarding, but the thing is that it depends on each area, it depends on each protocol, on each population, and usually getting into this would be too big for the scope of this video. That's why we already talked about the 3 most common protocols and what they say about pharmacological treatment. Now getting to the extra part. The extra part is kind of a recap for everything that we talked about. For example, we can take this diagram to better understand how to deal with patients with gastroenteritis. We have a patient. This patient is a child. We should look about directly to the nutrition of this patient. If the patient is breastfed, we should continue through rehydration and maintenance phases. If the patient is non-breastfed, then we should rehydrate for 4 hours, then go back to normal diet. If after normal diet and rehydration in non-breastfed patients, we have severe diarrhea with acid stool pH and reduction of stool substances by less than 0.5%, we should consider lactose exclusion. But this is a rare case, and we should use this diagram for patients with lactose intolerance. Next one, we have a patient with gastroenteritis. Does he have signs of dehydration? We see he has normal signs of dehydration. Then we should see the risk of dehydration. If it's low, then we advise on risk feed and ad libitum, which is as much as he wants. If he has high risk, then we should have maintenance feed, which is the increased amount of fluids needed per day, alternating with ORS, or we could add 10 milliliters per kilogram per each episode of stool. If the patient has mild to moderate rehydration, then the patient takes ORS. 4 hours, we reassess, and if the patient stays within moderate, then we continue. If it goes back to normal, then we go back to the normal rehydration status and we just give maintenance. If we are talking about severe, then we should give IV boluses. This is mostly according to the British diagram and protocol. Here we have a specific diagram for the fluid losses according to each area of the child's body, and how we use these losses to understand how we should replenish the fluids. For example, if the patient is having vomiting or NG tube loss, we see that the gastric fluid has increased amount of sodium and chloride and H+. So excessive loss can cause hypochloremic metabolic alkalosis because we are losing chloride, potassium, and H+. So the patient will need supplementations of potassium and chloride. That's why normal saline is really effective for these patients. If the patient is having diarrheal loss, then we see that most of the loss is basic. We have bases, which is HCO3, we will have potassium, and we will have sodium. They are all in really high concentrations. If the patient has mostly jejunal loss through stoma and fistula, we see that we have more loss in chloride if we compare it to diarrhea. And that's how we used these data to get into the ORS formulation. And it's to understand how we could stratify our patients with risk according to vomiting or according to diarrhea. These are the assessing scales, and they are usually used for risk, not for treatment, as each protocol has its own treatment assessment scales. But these are the most common. You have the WHO according to plan ABC, we already saw it. We have the Gerlich, which is according to only two stages. And we have the clinical dehydration scale, which is the same as the body deficit. It has the same symptoms. Here we have an interesting diagram. It is a diagram that compares all the protocols from the world and the amount of evidence it gives us for each of their recommendations. And as we can see, the Canadian ones have really high recommendation. If we look at the NICE, they also have really high recommendation, with multiple being 2 pluses and some of them being with 1 plus. If we look at Botswana, for example, they don't do it according to evidence classified by the grade system. They use it more according to recommendations. So they put everything according to the recommendation of their own scientific specialists, but they don't try to maximize the evidence. If we see Latin American, they have really high evidence for zinc, probiotics, and resveratrol, and this can be seen according to their own research on their own patients. And the European ones have high evidence level. And according to this diagram, some patients in countries that don't have their own protocols can use this diagram to understand which one is closer to them and is easier for him to adopt. Going back to the same diagram but a bit different, we can see that some of them having pluses recommend probiotics, for example. In the first one, we can see that the European one recommends probiotics. The NICE ones, the UK one, don't recommend it. If we talk about antimotility agents, almost all of them don't recommend it. And some of them don't even mention them. If we talk about absorption, some of them do, some of them don't. And this diagram can help us to understand some of the more common stuff and some of the non-common stuff. For example, all of them go against antimotility. But if we talk about probiotics, we have mixed. If we talk about resveratrol, you also have mixed. And if we look at zinc, we can see that the underdeveloped areas such as Botswana, Kenya, Latin America, South Africa, Indian Pediatric Society, they all recommend it, while others just don't even mention it. Here we have the last, and for me it was the most interesting comparison. It was between the European one, which was updated in 2014, and the NICE one, the 2009 version. We can see that for the assessment of severity, clinical and weight comparison is the most important. And for the UK, the red flags are the most important to assess for severity of dehydration. If we talk about first-line rehydration, for the European protocols, we have rapid over 2 to 4 hours with standard hypoosmolar ORS. It is the same ORS for NICE, but they use more. They use 50 milliliters per kilogram, while over 4 hours, while the European, they don't give a specific amount. They give 20 per milliliter per kilogram for 2 to 4 while assessing the patient. If we have shock, the European ones recommend 0.9% normal saline or Ringer lactate with bolus twice, with a total of 60 milliliters per kilogram. While the UK ones, they use 0.9 plus glucose boluses of 20, then 100, which is double the amount used by the European ones. If we talk about hypernatremia, they have almost the same. If we talk that hypernatremia that requires IV, then we have a little bit difference, that they use glucose for 48 hours to maintain and replace, while Like for the UK, it is the same. But for the French one and the European one, it is 0.9 for fluid deficit and glucose only for maintenance. If they talk about management of emesis, which is increased vomiting, the UK one don't mention it. But the European one mentions ondansetron. They both don't recommend loperamide. They both don't recommend antibacterial. And they both recommend early feeding. But the UK ones only start with solids after rehydration have occurred. And they avoid fruit juice and carbonated drinks until the diarrhea is fully done, while the European ones don't mention specifics. And the European one don't have a specific guideline for parents and carers, while the UK one does have. And if we talk about preventive measures, the European one also doesn't mention it, but the UK one mentions it. The UK one have a more emphasis on preventing and starting the treatment at home, and they try to avoid IV as much as possible. This is one of the reasons why it makes it a little bit special within the European Union. For more information, it would be really interesting if you could read the actual document of the protocols, because they give really good insights on the research done to get to this phase of the recommendations and this phase of the protocol. Thank you for being with us in this really long group video and this really long group of information. Hope that it was beneficial for everyone. And this was the last video in our series of intestinal infections. Some extra videos might be done about specific pathogens, but for now, this will be the full course of intestinal infections. Thank you for being with us for this journey, and hope to see you soon.